Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Yield of Screening for Long-Term Complications Using the Children's Oncology Group Long-Term Follow-Up Guidelines by Wendy Landier et al. My name is Kevin Effinger, and I am the director of the Adult Long-Term Follow-Up Program at Memorial Sloan Kettering Cancer Center in New York City, USA. My specialty is family medicine. As with others, I continue to marvel at the advances introduced by our pediatric oncology community that has led to an ever-increasing cure rate. Unfortunately, we have also learned that this cure comes with an often unavoidable cost, even with contemporary regimens. Simply stated, the developing organ systems of children are vulnerable to the toxic effects of chemotherapy and radiation. This is frequently compounded by the necessity of major surgery for local control of the cancer. Investigators from the Childhood Cancer Survivor Study found that by 30 years after the cancer diagnosis, or for example by age 35 in a patient diagnosed with their cancer at 5 years of age, almost 75% of survivors had at least one chronic condition, and 42% had a severe, disabling, or life-threatening condition, or death due to a chronic condition. In the past 2 decades, we have learned much about these outcomes, generally referred to as late effects. Investigators have characterized the types and severity of problems that can occur following different treatment exposures. This information is the foundation for the Children's Oncology Group, or COG, long-term follow-up guidelines available online at survivorshipguidelines.org. These guidelines were developed as a tool for clinicians to assist in the care of childhood cancer survivors, recognizing that diagnosing and treating a late effect at an early stage can reduce the burden of morbidity and the risk of premature death. The COG guidelines, first released in 2003, undergo continual review and refinement by a large multidisciplinary group. In this study, Landier and her colleagues studied the clinical utility of the COG guidelines in the annual evaluation of 370 childhood cancer survivors who were followed from 2003 to 2010 in a long-term follow-up clinic. The survivors were on average 24 years of age when first evaluated in the clinic, ranging in age from 5 to 57 years. This wide age distribution highlights one of the many strengths of the study, with almost a quarter of their population being at least 20 years from their cancer diagnosis. This allowed Landier and her colleagues to evaluate the utility of the various screening tests recommended in the guidelines across multiple age intervals. Similarly, the study population had a wide and representative distribution of cancer diagnosis and therapeutic exposures. Over the 7-year study period, Landier and colleagues ordered almost 5,000 screening tests during the course of 1,188 clinic visits. Providing insights on serial annual testing, 60% of their population had 3 or more evaluations. Impressively, they reported that over 98% of the tests were completed and interpretable, meaning that the guidelines were rigorously and systematically applied in screening asymptomatic survivors over an extended period of time. They used a sophisticated analysis to evaluate incident-positive test results while also reporting the overall prevalence rates, including conditions diagnosed prior to the clinic visit. They used a clinically intuitive approach to categorizing the yield for the various screening tests in diagnosing a new condition. A high-yield test was defined as one in which 10% or more of the screened population had a positive test and condition. There were 5 high-yield tests: a TSH, a ferritin, an audiogram, a DEXA, and pulmonary function testing. While these findings will not surprise clinicians who frequently follow long-term survivors, there are several caveats to emphasize. First, these findings remind us that while some outcomes are evident soon after the completion of therapy, others may not develop until many years later. Hypothyroidism following radiation that includes the neck region is illustrative of this latter paradigm, with an increasing incidence over time. In this study, 30% of the at-risk survivors had already been diagnosed with hypothyroidism. With follow-up over a relatively short period, another 10% of the remaining at-risk group developed hypothyroidism. In contrast, the incidence of iron overload does not increase after the last blood transfusion unless there's another contributing factor. However, iron overload has only recently become recognized as a late effect among those receiving multiple blood transfusions, and thus most of the survivors seen by Landier and colleagues had not been previously screened for this condition. The yield of this test was impressive. Almost a quarter of at-risk patients had a ferritin level higher than 500 nanograms per milliliter, a level warranting further evaluation. The yield of two of the other screening tests, PFTs and an audiogram, remind us that survivors will often tolerate a loss of function and be considered asymptomatic simply because they adapt to the restrictions of their disease. I will remember a previously athletic young adult survivor who had seen multiple clinicians who did not feel she had any pulmonary problems, since she reported to them that she ran 2 to 3 miles every day or two. Her pulmonary function tests, though, were consistent with the running speed she described. She had severe restrictive lung disease, and it took her almost 20 minutes to run a mile, a pace that many would consider walking. Landier and colleagues also reported several tests with an intermediate yield, defined as 1 to 10% of the screened population with an abnormality. Included were tests for renal tubular dysfunction, hepatitis C antibody in patients treated prior to 1993, breast cancer screening, and testing for left ventricular dysfunction. In other words, serious outcomes for which an intermediate yield is highly acceptable from a policy perspective. Lastly, the study highlighted several tests with either a negligible or negative yield, defined as less than 1% of the screened population with a positive test. This group of tests is important for clinicians and policymakers to consider as we seek to curb the cost of health care and avoid overtesting. A urine analysis to screen for bladder cancer had a 0% yield in 267 at-risk patients with 845 screenings, including many survivors in their mid-adult years. Bladder cancer is a rare late effect, and a urine analysis has a high false positive rate. The understandable concern of clinicians is the fear of missing an early and treatable bladder cancer. However, while an inexpensive test, the cost of an annual urine analysis over a lifetime in almost 3/4 of the study population would not be trivial. Similarly, screening EKGs for anthracycline-related conduction abnormalities and CBCs for myelodysplasia or acute myeloid leukemia had negligible yield. Was this simply the result of a small study population, or are these tests that might be omitted from the COG guidelines? To answer this question, replication of these results by other groups is needed. In fact, this rigorously designed and conducted study by Landier and colleagues serves as a model for future investigation of the yield of screening tests recommended in the follow-up of survivors of both childhood and adult cancer. Such data and a better understanding of the screening metrics of different tests are necessary to optimize the care of cancer survivors. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.